Welcome in, let's make it breezy, learning meds with Pharma Made. Today we are breaking down a core concept that underpins everything in the cardiovascular medicine, that is blood pressure. What it is, how it works, and why understanding it is the key of mastering the conditions like hypertension, heart failure and kidney disease. So let's jump in. What is blood pressure? Blood pressure or a BP is the force your blood exerts on the wall of your arteries as it is pumped by the heart. Simple, right? But this pressure is absolutely critical to the life. It keeps blood flowing to your brain, your kidneys, your muscles, basically everywhere. Think of your circulatory system like a garden hose. The heart is the faucet and the blood vessels are the hose. The pressure comes from how hard the faucet is turned on, that's your cardiac output, and how narrow the hose is, that's your vascular resistance. Put those together and you get the golden formula, that is blood pressure is equal to cardiac output into SVR, systemic vascular resistance. So cardiac output is nothing but how much blood the heart pumps per minute, and the systemic vascular resistance is equal to how tight or the relaxed your blood vessels are. Let's simplify this for you with an example. Imagine your heart is an engine of the car and your blood vessels are the roads. A stronger engine, that is high cardiac output, you can move fast, and the narrow pumpy roads, that'll be high resistance, you'll struggle to drive smoothly. When either of those are too high, your pressure rises, that's hypertension. And it is not just a number, it's the silent killer that can damage your brain, eyes, heart and kidneys. But here is the good news. Newly, every blood pressure medication we use works by modifying the formula, and that's exactly what we are about to dive into the next. We will explore exactly where each class of antihypertensive drug work using the RAAS pathway, that is Renin-Angiotensin-Aldosterone System, and the compensatory mechanism the body uses to fight the low blood pressure. You will never forget how ACEi inhibitors ARBs actually work, because they are going to break it down visually and clinically. So don't go anywhere, this is where it gets good. Now let's see the compensatory mechanism in the hypertension, the RAAS system. Alright, now that you understand the basics of blood pressure, let's go deeper. Your body is hardwired with an incredible backup system to fight the low blood pressure, and the most powerful one of them all is the Renin-Angiotensin-Aldosterone System, or simply the RAAS. This system is like a smart thermostat of your blood pressure. It senses when the pressure drops and kicks in to crank it up back. So we start with RAAS pathway, that is Renin-Angiotensin-Aldosterone System. Now let's see what is renin, which organ produces it, what are the factors prompting the renin secretion from the kidneys, and its importance in physiology. Renin is an proteolytic enzyme primarily released from the kidneys that plays a crucial role in regulating the blood pressure and maintaining the fluid electrolyte balance. When blood pressure falls or the kidney sense the low sodium or low blood flow, a signal is sent from the special cells in the kidneys called juxtaglomerular cells. These guys release the renin, the first domino in the RAAS cascade. Example, think of renin like an emergency dispatcher that gets the whole rescue team moving. Now, renin travels to meet the angiotensinogen, a protein constantly released by the liver. Renin cuts it and turns it into the new molecule, that is angiotensin 1. Pro tip here is angiotensinogen is an inactive until the renin activates it, just like a key unlocking the door. Let's see what happens to angiotensin 1. Angiotensin 1 is converted into angiotensin 2 with the help of an enzyme, angiotensin converting enzyme, which is used by the lungs. Now the angiotensin 2, the real heavy hitter of the system. Example, angiotensin 2 is like a bossy manager. It starts giving orders that raises your blood pressure fast. Now let's see what this angiotensin 2 does. Angiotensin 2 has three major effects that all raises the blood pressure. First one is the vasoconstriction. It tightens the blood vessel by acting on the AT1 receptors, increasing the resistance and the blood pressure. And the second effect is it stimulates the aldosterone release from the adrenal gland, leading to the sodium and water retention. More volume means more pressure. And the third effect which angiotensin 2 does is it stimulates the antidiuretic hormone, which is also known as an vasopressin release, and triggers the thirst, making you retain even more water. It's just like a full body pressure raising plan. Now the angiotensin 2 is converted into angiotensin 3 and angiotensin 4 with the enzymes enzymes like angiotensinase. These angiotensin 3 and 4 causes the increased aldosterone secretion and vasoconstriction. Now, how do the medication work on this pathway? Here is a cool part. Modern antihypertensive drugs are designed to target the different steps of this very pathway. Let's map it out using our diagram. Renin inhibitors like aliskiren block the very start, no renin, no cascade. And the AC inhibitors that starts with the prils block the enzyme ACE, angiotensin converting enzyme, so angiotensin 2 never forms. And the other category of the drugs is angiotensin receptor blockers, the drugs that ends with the sartans, blocks the angiotensin 2 from binding to the AT1 receptor. Aldosterone antagonists like spironolactone block the aldosterone's action, so water and the sodium aren't absorbed. And that's not all, other classes also tie into the system. Beta blockers reduces the renin release by blocking the beta 1 receptors in the kidney, and the thiazide diuretics help excrete the sodium and the water, thereby lowering the volume. Calcium channel blockers lower the resistance by relaxing the blood vessels. For more information on the calcium channel blockers, I will leave you the link below in the comment section. Now it is an clinical example time. Let's say a patient has a chronic hypertension with the albuminuria. What's your go-to class? That is ACE inhibitors or ARBs, because they protect the kidneys by dilating the afferent arteriole and reducing the glomerular pressure. But if the patient develops a dry cough or angioedema, it is time to switch to the ARBs, because ARBs don't raise the bradykinin. And there you have it. The RAAS system decodes with the clinical logic and pharmacological precision. Up next, we'll look at each class of an RAAS inhibitors in detail, side effects, dosing pearls, and USMLE level facts you need to know. To wrap it up, so far the pathophysiology includes increased activity of the sympathetic nervous system and Renin-Angiotensin-Aldosterone System, that is RAAS pathway, leading to increased levels of the neurohormones like norepinephrine, angiotensin 2, aldosterone that can increase the blood pressure. Most medication used to treat hypertension target these neurohormonal pathway, as we saw the compensatory mechanism in the hypertension flow diagram on the. Now let's see Renin-Angiotensin-Aldosterone System inhibitors. Angiotensin 2 causes the vasoconstriction and increased release of the aldosterone. This results in sodium and water retention. RAAS inhibitors decrease BP by inhibiting the effects of angiotensin 2. AC inhibitors and ARBs have been shown slow the progression of chronic kidney disease. Angiotensin 2 constricts the efferent arterioles of the nephron, causing the increased workload in the glomeruli over time. This results in the kidney damage. Blocking the angiotensin 2 causes the efferent arteriole vasodilation and decreases the glomerular filtration pressure. In the heart failure, AC inhibitors and ARBs protect the myocardium from remodeling effects of the angiotensin 2. The RAAS inhibitors should not be used in combination. Example, AC inhibitors plus ARBs should not be given together due to an increased risk of adverse effects. Angioedema is potentially fatal adverse effects that can occur with the use of any drug. It is more common with the AC inhibitors that ARBs or aliskiren, and black patients have the higher risk. For testing purpose, if a patient develops an angioedema with an RAAS inhibitor, other RAAS inhibitors should also be avoided. Now let's see angiotensin converting enzyme inhibitors. AC inhibitors ends in the pril. They block the conversion of the angiotensin 1 to the 2, resulting in decrease in vasoconstriction and decrease the aldosterone secretion. They block the degradation of the bradykinin, which is thought to contribute the vasodilatory effects and side effects such as dry, hacking cough, and angioedema. Now see few of the commonly used examples, that is enalapril, lisinopril, ramipril, and captopril. These are pregnancy category D drugs which causes the injury and death to the developing fetus. Discontinue as soon as the pregnancy is detected. These are contraindicated in angioedema. Do not use in bilateral renal artery stenosis since the renal function will worsen. Do not use concurrently with the aliskiren and patients with the diabetes. Warnings include angioedema. If occurs, do not use it. Avoid concomitant use with another ARB or aliskiren due to increased risk of hypotension, hyperkalemia, and renal dysfunction. Avoid concomitant use with an aliskiren in patients with the GFR less than 60 ml per minute. Renal impairment and hypotension can occur upon initiation in the patients who are the salt or the volume depleted. Example, those treated with the high doses of diuretic. Correct the volume depletion prior to the administration. Rare warnings include cholestatic jaundice and the hepatic failure. And the common side effects with an AC inhibitors are cough, hyperkalemia, hypotension, dizziness, and headache. Captopril has more side effects like taste perversion and the rash. As we discussed that it causes the hypotension and hyperkalemia, those parameters should be monitored regularly. And the bonus point under ACE inhibitors is ramipril is taken once daily at the dose between 2.5 to 20 milligrams. It is specially preferred in the patients with the heart failure or diabetes thanks to strong cardiovascular protection shown in the HOPE trial. While ACE inhibitors are highly effective, not all patients tolerate them well, especially due to side effects like persistent dry cough or the rare but serious angioedema. And that's where the ARBs comes in. ARBs is nothing but angiotensin-2 receptor blockers, offer the same benefits without the bradykinin related side effects. Now let's dive into ARBs. ARBs or angiotensin-2 receptor blockers. ARBs, those are the drugs that ends with the sartans like telmisartan, irbesartan, losartan, olmesartan, candesartan. They block angiotensin-2 from binding to the angiotensin-2 type 1 AT1 receptors on the vascular smooth muscles, preventing the vasoconstriction. This means less sodium retention, less blood vessel narrowing, and ultimately the lower blood pressure. Simple, clean, and effective. Mechanism of action. Unlike the ACE inhibitors, ARBs do not block bradykinin breakdown, so the risk of dry cough and the angioedema is much lower. That's why ARBs are the go-to option for the patient who cannot tolerate the ACE inhibitors. Clinical uses of ARBs is hypertension, heart failure, diabetic nephropathy, and chronic kidney disease. Just like ACE inhibitors, they protect the kidneys and the heart, making them a powerful long-term therapy. Side effects and safety tips include: the most important one to watch is hyperkalemia, that is an high potassium. Also, ARB should be avoided during the pregnancy and never used together with the RAAS inhibitors like ACE or aliskiren due to increased risk of renal injury. And remember, never mix the ARBs and ACE inhibitors. It doesn't double the benefit, it doubles the risk. To master the ARBs, just remember, love very odd things in the calm, easy atmosphere. L for losartan lowers the uric acid. V for valsartan, which is vital for the heart failure. O for olmesartan, watch for an odd spur like enteropathy, which is a rare side effect of some blood pressure medication, especially with the olmesartan. It causes the chronic diarrhea, that means long-lasting watery stools. It also leads to the weight loss even if you are not eating normally. Inside the body, it damages the lining of the small intestine. Doctors call this as an villus atrophy. The symptoms look a lot like celiac diseases, but there are no gluten sensitivity. The main treatment is stop the drug. Most patients feel better after discontinuing the olmesartan. If someone on the ARBs has long-term diarrhea and a weight loss, this condition should be suspected and tested. Next one on our mnemonic is T. T for telmisartan, targets the metabolic fat. I for irbesartan, ideal for the diabetic nephropathy. C for candesartan, cool in CHF. E for eprosartan, ejects fast. And A for azlisartan, amazing blood pressure control. Stay healthy, stay cheesy with Pharma Made. Follow for more.